It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is trauma victim acute to chronic pain prediction and prevention. So let's begin today's session, for which I would like to invite Dr. Jayashree Sood ma'am to take over. Over to you, ma'am. Kindly proceed with the talk.
Thank you, Shreyashi, for starting the webinar. Good evening, everybody. It's indeed a great pleasure to host this webinar today. In fact, this is the 189th ICA webinar that is being conducted regularly for the past 3 years, and we take great pride in it that we have been able to do it successfully. However, this has been possible only because of the faculty that has contributed to these webinars. ICA can do nothing all by itself, but the members and other invited faculty contribute so much that these have become so very popular. So once again, today we have a very, very interesting webinar, and this is on a trauma victim, and it is the transition from acute to chronic pain in a trauma victim. So important, such a vital topic, prediction and prevention. And for this webinar, we have Dr. Jitinder Kaur Makkar as the webinar moderator. She is the professor at the PGI Chandigarh, a very reputed center. We all know PGI so well. And it's so good that we have such elite faculty who's going to be here as a faculty, as the speakers, and of course the moderators too are excellent. So Jitinder, please introduce the moderators so that they can go ahead with the webinar. Thanks a lot.
Thank you very much, ma'am. And at the onset, I would like to thank ICA for giving me the opportunity to host this webinar. I must thank Dr. Radhakrishnan when he said you have to do it. So I kept on thinking about the topics, and then it came to my mind that this is one area which is not touched, and I need to get it on an Indian platform. So before I start with the webinar and introduce my moderators, and moderators will introduce the speakers, I'll just like to have the viewers a brief overview of why did we decide to do this webinar. Well, we after any trauma, it is expected that there would be a pain and discomfort, and usually it is expected that it would heal by itself, but unfortunately the pain continues after the physical injury heals, and this continuation is called post-traumatic pain. Now the agony is that there is no definition of post-traumatic pain, probably because people are not aware of this entity. So I thought, let me pick up this topic at this crucial time so that our delegates are aware of what this entity is, and how can we maybe stop the progression of acute pain to chronic pain in trauma victims. So with this target, building upon these considerations, I would like to tell you that we have 4 talks. These 4 talks are going to cover acute pain, chronic pain, and then how to prevent the transition between acute and chronic pain. Unfortunately, it's a very wide topic, and because of scarcity of time, I just included 4 topics. And our first moderator is a very dynamic person who has a very strong commitment in the field of anesthesiology, and I would like to invite her to introduce our first speaker. To introduce the moderator, Dr. Kajal Jain has been working in the field of anesthesia for nearly 30 years, and she holds the position of professor in the Department of Anesthesia and Intensive Care, PGI Chandigarh. Professor Jain has been the course coordinator for DM trauma and acute care for nearly 8 years. Working with her over 8 years, I've seen what trauma patients are like, what is the extent of pain these patients have in post-operative period, and her knowledge has been impacting the students, DM students in the field of trauma anesthesia. With over 100 publications in national and international journals, she has made a significant contribution to the field of both obstetric and trauma anesthesia. So I invite you, madam, to introduce our first speaker, Dr. Hense Clark.
Thank you. Thank you so much, Jeet, for the introduction to the webinar and my introduction as well. And as we all know that ICA is committed towards, creating awareness of latest updates in anesthesiology for the last 3 years. And in this unique endeavor, this week, I'm very happy to note that it is covering trauma anesthesia, which is very close to my heart. And even more close to my heart is the first topic, of course, all the topics, but the first topic, I'm very interested to know what Dr. Hensi Clark, who hails from Canada, Toronto, and is currently working as an associate professor in the Toronto General Hospital. And I've seen through his CV that he is a very accomplished doctor in the field of pain medicine. He has various degrees like fellowships in chronic pain management, and he has been awarded so many teaching mentorship awards through his career. And I'm so delighted to have him on board with us today, this early hour, 8:30 a.m. I'm sure he has to start his day today. And he's here with us to speak on translational pain services and what is the role of trauma center. Dr. Hensi Clark, I'm extremely delighted, and I'm looking forward to hearing from you what you have to teach us so that we can also incorporate those clinical nuggets into our practice here in India. So the stage is all yours. I welcome you to please come and address our viewers and our audience on this topic today.
Well, thank you very much, Dr. Jain. I'm just going to pull up my slides here, and I want to thank Jatinder for the invitation. I think it's going to work. Let's see what happens. I tried this yesterday. And I think I live in my slides, so it's as we hoped. Okay. Again, thank you very much. It's a pleasure to be here to talk to you a little bit about transitional pain services. And I know we're focused on trauma. So what I plan to do is talk a little bit about how we built this in the post-operative care and already show you a couple of examples of how this is playing out in the rest of the world. And you know, a lot of people have thought about the similarities between trauma and between surgical experiences, whether that's elective, whether it's cancer and oncologic surgeries. The development and the progression to pain disability after significant injury continues to be a major problem. So, you know, when we start with where we built these services and start with these programs, we knew we do over 300 million surgeries worldwide on an annual basis. And we've always had a very rudimentary way of figuring out how people are doing long term. And that was simply asking them their pain score and whether or not they had a pain problem. And this is a very complex issue. We all know that the mental health piece of this, the trauma, the PTSD, all of these things play into how these folks do long term. And even from a surgical perspective, you know, if you look at the people that struggle 1 year after surgery, you're looking at about 8%. And 8% of 300 million individuals annually is a big number. And that iceberg, you know, image there really speaks to the fact that we only see the tip of the iceberg and the amount of disability that ensues for many folks, and particularly post-trauma, post-surgery. This is a bigger issue than we all appreciate at times. And so, from a surgical perspective, pretty similar in the trauma perspective. People who come in already with a pain issue are probably going to be at higher risk. If you have, you know, worse pain outcomes perioperatively, that's going to be an issue. You know, the younger you are, the more susceptible you are to the PTSD trauma. You've not had issues like this before in your life. It's the first time you're seeing this. You know, women are always at higher risk for any pain and disability problem than men for various reasons. And your psychological state really does a lot in terms of predicting how you will do long term. So, you know, this is Toronto General Hospital. This is my home hospital. This is where we built the first transitional pain program. We have a big oncologic center. We have a cardiac center, and we do a lot of transplant medicine. Just up the street, however, we do have a major trauma center at Sunnybrook, and they have actually started a transitional pain program in their trauma center with some of their surgeons there. And so, you know, when we started this, we really looked at how people were doing immediately post-operatively. We know that in the setting of neuropathic pain, those folks who have significant pain at that 72-hour period and are telling us about these electric shock-like issues and the burning symptoms associated with these, about 70% of these folks continue to have these at about 6 months. And so it's a real flag early on when someone is telling you they have these neuropathic symptoms, and these are moments where we can intervene. And classically, we hadn't intervened for these patients until they came back months and months later with these conditions that were plaguing them. And so the earlier we can jump on some of these things, the better patients can do long term. Now we obviously get pre-surgical referrals, and we're getting a lot of our post-op patients who see their surgeons early on requiring opioids and or continuing with a pain issue to get sent to us. This transitional pain concept is clearly one that supersedes just the surgical setting. So we're talking about this acute to chronic pain transition. You can see that in medicine, this pediatric to adult, adolescent to adult, there's a big transition there. Hospital to community in particular, and whether you're talking about trauma patients in general, whether they're transitioning to rehab and then transitioning beyond that or back to home. And in North America in particular, we talk a lot about transitioning patients that have been on these legacy high doses of opioids onto things like buprenorphine and naloxone. And over time, we've realized that we become a bit of a medication cessation program to stop specific medications that have just become barnacles on patients as they go through the system when we see them in the outpatient pain program. We were really getting a lot of criticism from some of our funders in terms of, we're putting out a lot of this research, but we don't have any guidance for the folks that want to build these programs or want to do similar things. And so I would encourage you to head to this website. We've created a PDF document, about a 30-page PDF document for the rest of the world and folks who would like to download this. It's been downloaded several hundred times in terms of across the globe. And this really speaks to what you as a physician can do, policymakers can do, your administration in terms of what resources you might need at your institution. This is not a one-stop shop cookie cutter type build. You use the resources you have, you leverage with what your administrators will help you and give you in terms of resources, and then build out a project and a program that makes sense for you as an institution. So this has been a pretty good resource if anybody would like to take a look at that. But what's clear is that any type of long-term problem has three solutions, and one is what the physician can do for you, what medications we can authorize, where we can put needles, and what types of blocks we can do. But ultimately, it's patient engagement in terms of getting back to moving, getting over their kinesiophobia, and obviously dealing with the mental health. The brain is as much of a player in this in terms of progressing beyond that initial insult and injury, whether it's surgery, whether it's trauma. You have to deal with the entire person as a whole. And that's really the tenet of how we built these programs. We were really one of the few programs built on that brain and behavior pillar as what we need to move forward in this space. And so we all know these neuropathic pain guidelines. This is the easy part of the program, where we treat individuals based on what symptoms they have and how we help them wean off of their opioids, etc. I would argue that the hardest part of this is tackling the patient with their mental health issues and some of the issues that are ongoing with their ongoing care. And this is where we have really relied heavily on our psychologists and our interventions that are occurring, in the outpatient setting to deal with how they're coping, how they're appreciating, how they're accepting where their new state is. And really having patients understand that once you've been cut open, once you've had a major trauma, it would be great to perceive that you would be back to the exact same individual you were before, but how do we set those new norms and how do we give you new goals to move forward, et cetera? And there's lots of literature to speak to these interventions from a psychological perspective at reducing pain, unpleasantness, reducing opioid use, and improving people's disability on an ongoing basis. One of the things that we spend a lot of time talking about are, those individuals who have been traumatized and been in a scenario where they're now afraid to get out of their bed, they're afraid to make a meal for their family. How do you move them towards some of these behaviors on top of the medical parts that are happening in the background? And we do this through a series of either individual sessions. We do have some group therapy. We've moved away from the groups given COVID, but we're talking about bringing some of those groups back. Our system, I'm sure, is similar to yours. It's overwhelmed. It's swamped. We can't see people on a one-to-one basis forever going forward. We just don't have the capacity to do that. And I'm really a fan of group behavioral therapy and things of that nature. So, on an individual basis, we don't offer psychology care long-term. It's typically about a 6 to 10 session intervention. If it's individual, similar group therapy or specific workshops over about a 3-4 month time period. And obviously we do go and see our inpatients when they're in crisis postoperatively to collect them and move them in as an outpatient and help them get discharged. And in a trauma setting, you can see how that would be significantly advantageous for the folks that have been in hospital quite some time after these major injuries. This is just to show you, we published this paper, actually just last week, last month it was accepted, looking at a clinical hypnosis intervention pre-surgery and then once on the ward, and looking to see how this translated from a pain perspective and an opioid consumption perspective. And so this was a clear kind of opioid sparing effect early in that first 48 hours. And we saw a significant reduction in terms of pain catastrophizing at about a week postoperatively. So some early data to speak to, again, using the mind, using the brain to help reduce some of these anxieties and reduce opioid consumption. What's clear is that, in this model of care, we're dealing not only with the medications, but specific acceptance of people's pain. And once people start to accept that this is now their new norm, and we move towards reducing this severity over time with medicines, with exercise, and with the brain, that we're seeing good improvements in terms of catastrophizing, anxiety, depressed moods. And we have multiple publications showing our opioid weaning successes in our patients. We now have been asked to do a randomized control trial, and that's where we are. We have a 5-site trial happening across the province here, looking at the standard of care to our transitional pain service model. And what we're looking at is a 1-year outcome of opioid use, but more so pain interference. And are these patients, given this multidisciplinary care at 1 year, doing better than others? We're about 140 patients into this. I still think we have about 100 more patients to recruit. It's been very slow because one of the things that we have asked for is that if people want a specific amount of opioids, and given the opioid crisis, there's been a real shift in opioid prescribing in our country in particular. So these are the next two slides that I think will be of significant interest to you. So this is in Norway. So I collaborated with Levar Roysland, and he's a professor at Oslo. And they have created a Norwegian trauma registry. And so they have about 27,000 trauma patients. And what they've done is they've now tagged it to their other patient registries and statistics. With Statistics Norway, we call it Statistics Canada. I'm sure you have something similar in India. And now what he's planning to do, and has already started, is to embed different care pathways in this trauma population. And so I have a meeting with him in a couple of months just to see what their progress is, and to see how far they have taken this transitional pain model in their population. And so this is Norway. Now, this was somebody else that I collaborated with from Australia. And what she has done there is exactly what you're talking about today. Putting together a bit of a pilot project, looking at individuals in the trauma setting and actually intervening with people who have high pain and high PTSD symptoms during their in-hospital stay. And what they did was they had a case manager that supported these patients. They gave them extra psychological care and other resources in terms of helping them navigate through this pathway. Again, pilot a small program to see if they can move forward and get some funding to build this out in a big way. And participants reported few disadvantage from the participation in this project. They had positive impacts on their symptoms and recovery outcomes consistent with the reduction in PTSD and pain symptoms measured at 1, 3, and 6 months. So again, some early evidence here in Australia, speaking to exactly what you have asked me to talk about today, and intervening in the trauma patient in particular. So, we knew with COVID, we had to start to track patients. And if you're going to track patients in that trauma setting, how do you look at them outside of the hospital? And so we worked with an app developer to build an application in which patients, and this is, I think, translated into 24 different languages. And I would think that some of the Indian dialects would be part of his translations. So it might be something you might want to look up and see if this is of use to you. And I could always introduce you to the program, but they have over 50,000 users across the world now, if not more than that. And it's the top pain app when it comes to people using this to track their pain. And what we decided to do was embed for our patients, not simply asking them about their pain, but what they're doing that mattered to them on a daily basis. And that's kind of our measure of success. I always say, look, if I can reduce your pain, that's great. But what I need to know is that you're getting back to making dinner for your family, that you're, engaging with life with your children again and moving those things forward. If your pain score stays at 4 for the rest of your life and you're doing more, it's still a win. And so, that's kind of the goals that I try to set for many of the patients. It's just a paper in terms of how we embedded it into our program and how patients engaged with it. And we did this really cool analysis where we put it into the urban setting, so those major settings, in the big cities, and we put it in a very rural setting where people had to travel hours and hours and hours to get to the hospitals in Northern Ontario, in particular the Indigenous population. And we asked, how does this kind of help? And we looked at engagement and looked at outcomes. And it was clear that in the urban big city centers, to give somebody an application on their phone, maybe you got 30 or 40% engagement. But when you reached out to those rural settings where, connecting with a physician was really difficult, these individuals engaged almost at 70%. So you give someone a tool to access interactions with healthcare, and they will use it when it's a scarce resource. In the urban centers where everyone can access care, it wasn't as big of a deal. But this is the first of its kind data to show that individuals that are tracking and using these tools for their pain scores, et cetera, have a reduced anxiety and reduced pain catastrophizing, ruminating about their pain, anxiety early, catastrophizing later on. So as they start to understand their symptoms and appreciate what's happening, this tends to lead to very positive outcomes. This is a paper that was just published in Regional Anesthesia and Pain Medicine. And it speaks to the fact, on the left-hand side for you, I suppose, is that flat line of what's happening in the community. But when you integrate a transitional pain service, you are picking out those distressed individuals, the 15% of the population that are doing poorly. And you can see that with the help of the service, they can be reduced almost back to where some of those folks are. And without the help of these services, these folks get really stuck in terms of some of their plateau and their peak levels. And so this was digging into health administrative database across the province. So the one side are the folks that are in the system, and the other side are the folks that we were pulling out, looking at that were at high risk for developing and continuing with opioids and going on to have significant pain disability and chronic pain. So I think, I'll wrap up now and I leave a few minutes for questions. But the thing about building a transitional pain service is that there's no doubt it's going to show value to your institution, whether it's in the post-surgical setting, whether it's in the trauma setting. I just spoke with an emerge physician who is actually coming through and did some electives with us. And it's similar there. You have patients coming in post, maybe not major trauma, minor trauma. They're being prescribed opioids. They're having things done to them. They walk out of the emergency department and nobody knows what's happening to them. And he's thinking about building in transitional programs even in that setting. So anytime there's a touch point after a major, impact to a human being, there's a transition point there that we can certainly intervene and help with folks. And so, one of my soapboxes is that every center that performs any type of surgical interventions, whether that's elective, cancer, trauma, needs a recourse for their patients that are struggling. And you start to realize as you do this is there's a huge intersection with pain, addiction medicine, mental health. All of these things work together, and we have to unsilo these care pathways so that we're all working together and building these multidisciplinary teams to help these folks. The mobile and the virtual access is just something we've added in the past years, but has really led to better engagement with some of these patients. And obviously talking about this and translating the knowledge, to others as you're building these things across India and across the world would be really important. And so I'll take this opportunity to invite you to our Canadian Pain Society meeting in Ottawa in a couple of months. I become the president at that point in time, and I would love to see you there. So thank you very much for the opportunity to speak to you this morning.
Thank you, Dr. Clark. Thank you very much. And your topic sounded very easy for you, but for us, it's like a very new thing. And I'm sure some of us would not have understood quite a few things. Even I am finding it difficult to understand what you have done, because you seem to be very proficient in all this. What I've understood in large is that we need to be more aware of it, first and foremost, because most of us are not aware of this translational pain. And we do not see them outside the operating theater and forget about seeing them at home and so on and so forth. So I just want to ask you, if I were to create a team in my hospital, who would be the stakeholders? Do you think
Okay,
there
so
is
it's
a
a great.
psychiatrist also on board, because so much of it is being talked about in terms of psychology?
So we have, it's a great question. So first of all, how would you start? And then I'll get to what we've developed too. This is our 10th year anniversary. So we've had this program now for 10 years. And I'll be honest with you, they tried to kill the program in the first 2 years, probably about 2 or 3 times, because what are you doing? Why are you not standing in the operating room? Where are the patients? Why is this even needed? And eventually the surgeons figured it out, the patients. And once you get a few patients that you really change their trajectory, and you entertain some discussions with your PR folks, and you get the stories to be told, hospitals love stories. And as anesthesia, we really get stuck in the OR and we get undervalued. And so, the perioperative period is more than just the operating room. It is also the post-op, and then obviously the chronic pain that ensues. We can play a major role in that. Not everybody wants to. It's very difficult. It's not an algorithm that you can just line up and tick box things off. And so that's why people kind of struggle in this space. Who would you start with? You would start with your acute pain service. Absolutely. That's how we started. You would need to have a separate outpatient administrative individual that could be booking. So if you have a chronic pain association, you probably have at least the hallmarks of that. And you definitely, in my opinion, would need some mental health support. And so we started with psychologists. My PhD supervisor was a gentleman by the name of Joel Katz, who had looked at all of these predictors of people that do poorly after surgery. And we thought, let's build something and stop talking about it to see if we can help change some of these trajectories of some of these folks. Currently, in the last 2 years, we have onboarded a psychiatrist, and he will help with some of the major, psychological comorbidities. So people scoring really high on the PHQ-9 or really high on the pain catastrophizing scales, we'll get them involved. But it's still a model where we triage first, and we assess each patient, and we determine who else needs to be involved. We have a physiotherapy involved in the program, physiotherapist obviously involved in the program. But to start, use the building blocks that you have. You have your acute pain team. You need someone to help coordinate outpatient visits. You need a couple physicians that have some training, outside of acute pain. And some of our docs, we had about 8 docs in our program. 2 have recently left. 4 were acute pain docs that had an interest in chronic pain, and 4 were chronic pain with acute pain interest. So you had a diffuse interest from individuals that were interested in being part of this program.
Yeah, thank you very much for that insight. And as a beginning, Dr. Jitendra will agree with me. We have picked up only one set of patients, because it's very difficult to start off, as you yourself said, that you are discouraged at times and people do not understand it, and it's so difficult to set it rolling. So we have started with amputations first. So I just told her to first work on one particular subset, and then slowly build on, because we are facing many challenges here in India. And what you were talking about, about the virtual calls, mobile calls and all that. So here we have a big challenge, because number one, most of our public doesn't have smartphones. And number two, they change their SIMs very often.
Right.
So the follow-up becomes very challenging.
So if you can't get a hold of them, you can't see them. So that's an issue. And
we have
what about online? Can you not do it simply as an online hub from the hospital?
That is also very difficult. But yes, we can. We have started somehow. But these are the things which I found that even you have taken 10 years. So for us, we should also think about that longer period, a decade and a half, before we can reach your level. There is one question in the chat box. I do not know whether it falls in your purview, but I'll read it out. How do you manage a super obese patient with severe OSA coming for upper endoscopy as a pre-bariatric surgery workup? So I think if you want to pass it off, then that's perfectly fine. We can later on, we can take this question.
Okay, sounds good. I'll leave it to your next experts.
Yeah. Sure. So, Jeet, do you have anything to add, or we can move on? Because
no, ma'am, I think he has given us a very good link of how can we set it up. Like I'm sure the PDF which you are saying, the link which you are saying is going to give us an information of how to set up transitional pain services. So that would be a very good information for all the viewers and us also. And it was a very informative talk. So I think we'll let you go. It was a very informative talk, and thank you for accepting our invite and being with us today, Dr. Clark.
Thank you for the
so much,
invite. It was
Dr.
very
Clark,
easy.
and we'll be in touch with you
Hope it was
if
useful.
we face any problems in starting up our translational clinic. We'll get
Happy to help, guys.
on that. Thank you.
Thank you, Dr.
Have a great day. Good luck.
And I would also like to thank Dr. Kajal Jain to, accept the invite and chair this session, she being a very busy person. So we'll move on to next talk. And for this, I would like to invite Dr. Sukanya Mitra to introduce our next speaker. Professor Mitra holds the position of Professor in Department of Anesthesia at GMCH Sector 32, Chandigarh. She has been instrumental in establishing acute pain services as well as chronic pain and palliative care services at Government Medical College and Hospital Sector 32. And she is recognized for her numerous international and national awards, and her diverse areas of interest reflect a comprehensive approach to pain management and education in the field of both acute and chronic pain. So I think Madam falls well into the category of what Dr. Clark said, both acute and chronic pain. So over to you, ma'am. I hand over the stage to you.
Thank you, Jeet. Very good evening to all of you. And it's my privilege to introduce Dr. Athmaja Thutungal. She is a consultant in chronic and pain and regional anesthesia, and she is affiliated to East Kent University Hospital NHS Foundation Trust. She also has multiple areas of interest, that is ultrasound guided interventions for all types of pain management, neuromodulation. She also takes active interest in lifestyle medicine and medical education. And obviously, she is an internationally renowned educator in regional anesthesia and pain medicine. And now, Dr. Thutungal is a practitioner of holistic approach to healthcare and well-being. She is also involved in number of community work and charitable initiatives, and she is the author and co-author of many chapters in the books and articles. The most importantly, what I want to say in a nutshell is that Dr. Thutungal is an excellent speaker, and we look forward to you, Dr. Thutungal, about what you are going to teach us today. And I hand over the mic to you to start your talk. Thank you.
Hi, can you all hear me well? Can you see me as well?
Yes,
Wonderful.
yes, thank you.
Okay, wonderful. Namaskaram. Good evening, all. Thank you ever so much for inviting me to talk about the peripheral neuromodulation in trauma patients today. It is such an honor, and also it brings back so many memories, especially very homesick again, seeing you all there. I miss India a lot. Anyway, thank you for the opportunity. So in the next 15 minutes or so, what I am trying to do is introduce the idea of the neuromodulation, specifically peripheral neuromodulation in the context of trauma. This is something that many people think, as a country with limited resources in many parts of the country, it is something that we may not be able to achieve. And I want to break that thought process in you. It is very much possible. There is a lot we can do with the limited resources, and it is helpful for our patients there. Okay, so these are my disclosures. I do have a few faculty positions in various organizations here, and I have received some funding in the past, but it has nothing to do with today's talk. So the topics today I'm going to cover, one is neuromodulation versus neurostimulation. And what is the mechanism of action of neurostimulation? Because that's something that I'm going to focus on today. And methods and its current use in acute as well as chronic pain, and also during the transitional phase of the acute to chronic pain as well. And what should be the future look like? And a summary at the end as well. So what is the difference between neuromodulation and the neurostimulation? Neuromodulation means altering the conduction of the impulses through the nerves. That can be due to electrical stimulation or a chemical, because the chemical one is the common one that we use using the different medications. But the neurostimulation is the one which we use the electricity as a method to alter the conduction through the nerves. So the neuromodulation agents, we all think about local anesthetic agents or oral analgesics, but we often forget there are many other things that we can use to achieve this. One is the steroids that we use, and the other ones that people probably in the acute pain world are not thinking about are Botox and also the chemical agents like alcohol and phenol, which may be useful in trauma setting, especially when they are coming for repeated surgeries as well. And also the intrathecal drug delivery system, which could be temporary or permanent, as you can imagine. So what is the mechanism of action of the neurostimulation? It can start from the periphery all the way to your brain, and wherever you intervene, it has got a reciprocal effect as well. So this particular article, which was published in the International Journal of the Molecular Science, the mechanism of action of the peripheral nerve stimulation in chronic pain. It is because most of the work is done in the chronic pain world, but it is something that can easily translate into acute or transitional pain area as well. So it is not just the periphery, even though we are talking about the peripheral neuromodulation, it has got both the ascending as well as the descending pathway actions, which works on the periphery, in the dorsal root ganglion, in the spinal cord, and in the higher centers as well. The QR code is there. By the way, if anyone wants a copy of the lecture, please feel free to contact me. I will give the contact details once again so that you can have a copy as well. So what are the peripheral neurostimulation techniques that are available? So I would divide that into non-invasive, minimally invasive, and invasive. So the non-invasive technique that can use in any setup is one is the TENS machine. People think TENS machine is something that only used in labor. It is not. You can use it for any kind of peripheral neuralgia. You can put it on the areas that is painful for. It can be used in trauma setting or even in the post-surgical period. The external neuromodulation is using a pen or like an electrical stimulator, which it is almost like an electrical TENS kind of principle, and also the vagus nerve stimulation. I'm very close to that concept of vagus nerve stimulation, which will come to you in a minute. And the PENS is the percutaneous, which goes just underneath the skin, and also the percutaneous peripheral temporary neurostimulation. If you have an access to a peripheral nerve stimulator, you can use this technique. It is as simple as that. And of course, the pulse radio frequency, the cryotherapy, or a permanent implant, I'm sure it may not be accessible for everyone in every part of the world, including UK, even in the developed countries. But I just wanted to put it out there because there are centers who are offering. So this is also available as a choice if you have got a patient who needs it as well. I don't need to introduce this guy to any of the anesthesiologists in the world who is interested in regional anesthesia. This is Dr. Admir Hasek. He is one of the Nysora guys. And in his experience, he talked about the TENS because this is one of the simplest and the cheapest method. Even as a guy who is like, living and breathing in regional anesthesia world, he had his shoulder surgery. And then he had post-operative period, post-trauma, the TENS machine to help him to recover as well. So it stimulates the A beta fibers, A delta fibers, as well as the C fibers hyperpolarization. This is how the TENS or the PENS works for the pain. Non-invasive vagus stimulation, this is something that we always forget about because we talk about what we can do as doctors, but we forget about the patient themselves. There are things that they can do. And as an Indian, we always forget about our roots. That is, one is yoga. Yoga is the vagus nerve stimulation, our autonomic nervous system, which helps with our homeostasis. The sympathetic overdrive we get as a part of the trauma or post-traumatic stress disorder, that has to be brought down. And the way to do that is stimulate your parasympathetic, which is your vagus nerve. You can have breathing techniques or your external stimulator of the tragus or your auricular branches or in the neck. That can be done as well. This is simple measures and it is easily accessible and approachable, applicable as well. Pens, I'm not quite sure this is freely available, but there are few centers who is using it. It is out there. I just wanted to put it out there. This one is my favorite, which is the peripheral percutaneous temporary stimulation, which is done using a conventional nerve stimulator, which is available in almost all ORs, all hospitals. And you don't need a lot. You just need a needle, which the connector that can be stimulated. That's it. And that is my choice because it is cheap as a chip. You can apply to any patient. So this is an example how the neuromodulation can give instant pain relief to the patient, and also how that makes their quality of life and improves their quality of life as well. So I hope you can listen to the video. So this particular patient, a severe shoulder pain, she doesn't want to have a surgery, but the pain is affecting her quality of life and the functionality. And this is what I do. So you identify the nerve, which is C5, C6. So this is like the patient feedback. They will tell you where the patient is feeling the stimulation. And this is a conventional nerve stimulator, and the parameters are slightly different. It is 2 Hertz, 0.2 to 0.3 milliampere current, 1 milliseconds pulse width for 5 minutes. And this is, I give like a half a mil of the local anesthetic, 0.25% levobupivacaine. And this is the response that you get immediately. So from that 30-degree abduction, this is what the patient can achieve. And I had a free hug for the patient as well. So C5, C6, you identify the superior trunk, you stimulate it for 5 minutes and then give it. The beauty of this is you can use it anywhere, perioperatively, intraoperatively, postoperatively, and it is reproducible. So you can repeat it if you need to as well, and it prolongs the analgesia. So these are the parameters. And the other one I just want to mention about is the pulse radiofrequency. There are many centers who offers pulse radiofrequency denervation or the radiofrequency in the chronic pain setup. This can be translated into the acute pain world as well, or the post or the peri-trauma period to prevent the neuropathic pain or the treat the neuropathic pain. Cryoneurolysis using the cold instead of the heat for the pain management. Again, this can be done as a part of your pre-surgical or the intrasurgical or post-surgical. This is more used in amputation. Dr. Kajal Jain was talking about the trauma patients, especially the traumatic amputation patients. This is something that can be useful for these patients because once you do the cryo, the analgesia lasts for up to 90 days. This is again another article. All the QR codes are given to there as well. So most of the data is in the chronic pain world, but do think you can learn a lot from the chronic pain transferred into the acute pain side as well. What about the semi-permanent, permanent implant? I know very few centers in offers the permanent or semi-permanent implants, but these are available. It can last like a 2 months to permanently in their body as your cardiac pacemaker. There are centers, but it is not a widely available technique. But I just wanted to put it out there for completion's sake. Again, these are the various articles where you can find if you are interested to know more about the peripheral neurostimulation technique as well. Okay. The vagus nerve is stimulated invasively as well. This is specifically used for different techniques like a chronic inflammatory disease, chronic neuropathic pain, convulsions, depression. That is another indication as well, where the vagus nerve can help you with that one as well. Trauma patients, they normally get a lot of depression or post-traumatic stress disorder. So dealing with their autonomic nervous system, specifically stimulating the vagus nerve, is so important as well. Let's go back to the physiology, the neurophysiology of the pain pathway, where it is transduction, transmission, modulation, and the processing or the perception happens at the various part of the nervous system. The neuromodulation can be applied throughout. It is not like the WHO ladder, where the paracetamol is centrally acting, non-steroidal is peripherally acting, and the opioid is in the DRG and the central nervous system. Neuromodulation is possible throughout. So as a proposed algorithm, if you are planning to apply the peripheral nervous system, non-invasive methods like the TENS external neuromodulator or the vagus nerve stimulation by the patient themselves is the first step. If it's minimally invasive, you have access to the nerve stimulator, you can try the percutaneous temporary stimulation or PENS. Or if you are in an advanced level or a center, you can try the pulse radiofrequency or cryotherapy. The permanent implants will be for higher centers or the specialized centers. So what existed before the peripheral nerves? You have heard of spinal cord stimulator or the DRG stimulator. If the patient is having any of these devices pre-operatively or the pre-trauma period, you can still use them in a different modality or different set to treat the post-surgical pain as well. So this is again another thought. You need to think outside the box. So what is the future that is going to bring in the neuromodulation world? I am so excited about this because as a lifestyle medicine physician, probably this is one thing I felt I was lacking as a doctor, or the clarity about this one. Because we always talk about what I can do as a doctor or what we can do as a doctor society, but we do not give enough information or enough power to the patient themselves. The future is going to be targeted nano neurostimulation. So specifically at the cellular level, you will be able to stimulate the patient. Again, I always go back to the basics, the physiology, the anatomy, where you want to introduce anything new. So we talked about the medication, we talked about the procedures. Why can't we talk about the patient factors or the patient themselves? So the relaxation response or the vagus nerve or the trauma, the stress, even Dr. Clark was talking about it, why it is important to deal with their psychology. And vagus nerve stimulation is one of the important thing for this, because the sympathetic block that we offer is to enhance the vagus nerve activity, which is the parasympathetic activity. And that is all controlled by the most important homeostatic system in the human body, that is the gut microbiome. The gut microbiome and the brain has got a bidirectional control through the hormones circulating through the blood, but through the autonomic nervous system as well as the enteric nervous system, which is coming through your vagus nerve. That is why it is so important to have that vagus nerve activated, which will help with your healing process from every aspect. So this article came in BJA, that is in 2019, about the pain and the gut microbiome's role in the regulation of the pain. It is not only for the trauma patients, musculoskeletal, inflammatory, neuropathic, autoimmune, abdopelvic, depression. All these are linked with the gut microbiome diversity of the patient. We even wonder, one tablet gives fantastic result to one patient, but nothing to the other patient. Why? Even the concept of NNT is because of the diversity difference in the gut microbiome. That is why certain patients cannot metabolize or get the result of the medication that we are doing. Specifically, the new post-operative pain and the role of the gut microbiome, this article has come up in the neurobiology of pain. This is a very interesting article if you are interested, because it says the microbiota metabolites control or regulate the peripheral and the central sensitization, which is predicting of the transitional and the chronic pain development as well. So stress itself, the post-traumatic stress or the stress related to the trauma itself can modulate this gut microbiome, and we need to pay attention to that as well. This is specifically the role of regional anesthesia. I mean, as anesthetists, as people doing the trauma all the time, we are so attached to our regional anesthesia. Even the role and the efficacy of the regional anesthesia is linked to the diversity of the gut microbiome of the patient. And in this article, again, this came in 2021, it says the analgesic consumption is inversely correlated with the alpha diversity of the gut microbiome. There are certain group of gut microbiome which you can do through the mapping of their feces. And further work is needed to understand the link between these two and how we can manage it as well. And the opioid consumption needed afterwards or during the operation is linked with this diversity, and it is inversely proportional as well. So it is not only what we give to the patient or what we do to the patient themselves are the important factor here as well. And this leads to the concept of personalized postoperative pain management or personalized trauma management, which is so important. In this article, Edward Mariano and his team is clearly saying every procedure, every trauma, every part of the body gets different pain perceptions or different postoperative pain. So we need to keep that in our mind. It is not one size fits all. You need to consider the patient factors, their pre-existing problems, their psychological level, and the surgical factors, what type of surgery it is. Is it a trauma or is it a post-surgical? Is it an amputation? What surgery is repeatedly done, and also the resources that we have. In India, we do have limitations in resources in many places. It does not mean that we cannot think outside the box. We are very innovative people in that aspect, and also make it like an enhanced recovery. So the enhanced recovery is focusing mainly on the surgical aspect. That is why recently we suggested something called RAPM. Basically means enhanced recovery or enhanced regional anesthesia and pain medicine concept. This is important because we need to incorporate all these newer ideas, newer techniques that is coming into the arena beyond that WHO ladder, where you give paracetamol, non-steroidals, and opioids, and some regional anesthesia here and there. We need to have that holistic approach to get the best benefit out of the patient's outcome as well. I always say this to my trainees. We as doctors, we are the gardeners. We are putting the seed of the procedure or the medicine into the patient. Patient is the soil. You may have the best seed in the world, but if you want to have the best outcome, you need the best soil. So focus on the patient, and that is truly the patient-centered care. As a summary, we can give fantastic pain relief through the pharmacological methods as well as the electricity. Some are simple, some are more invasive, but think outside the box. We have to learn from each other. It is not just a trauma in theater. It is pre, intra, and post as well. Ultrasound skills definitely will give you that upper hand because you can think outside the box to target these nerves. Electricity, that is what is conducting through the nerve. You can modulate it through the electricity as well. And don't forget, the autonomic nervous system is your biohomeostatic system. Look through that, tap into that, think about the microbiome, think about the vagus nerve stimulation, how we can achieve that one as well. Thank you for listening, and thank you for this wonderful opportunity. And I would like to invite you for our RAUK meeting, which is coming in May. Please come and join us. And this is my details. If anyone wants to contact me or ask questions or have a copy of the presentation, feel free to do that as well. Once again, thank you, and enjoy the rest of the meeting. Namaskar.
Thank you, Dr. Atmaja. That was a wonderful talk. And really, I think you did show a lot of way where we can think out of the box. And the first thing is that you're talking about the pen, like since I don't see any questions in the chat box, I just want to make a comment that we have something called the Stimupod, it is a pen, and we used it for chronic pain patients, and the patients had really, like, we worked on a number of patients, yet to publish that, but patients did have 50% less, had a score after this stimulation. And my question to you is that, see, since you say that the gut microbiome do play such a big role in our, perioperative pain for the patients. So then, do you think it may be a good idea to start some yoga or say, therapies like something for the patient, mindfulness, yoga for the patient preoperatively, like preemptively, we give medicines to the patients, to modulate the pain. So, what about that? What is your take on that?
I think that's a very, very interesting question, and congratulations on trying various techniques to neuromodulate. I think it is so important. We mess up patients' gut microbiome, giving antibiotics, proton pump inhibitors, even the stress. So it is important that we help them to regrow. So where does the gut microbiome grow? They grow on fibers. So the diet is so important. High fiber diet is something, or the prebiotics or the postbiotics, or that is one thing that we can ask the patients to have. So nutritionally balanced. It is not like a high protein, high calorie diet, but more fibers. So ask them to eat more varied vegetables, fruits, and legumes to improve their gut microbiome. We can supplement with the gut microbiome. And also their stress management is important. And also imagine simple activities, whether it is physiotherapy or even walking in the nature, this all will enhance your gut microbiome. And also the vagus nerve. So it should start pre-emptying and prehabilitation should become a part of the post or the rehabilitation process as well. So when we talk about it, think about the hospital, forget about the hospital. As doctors, what do we eat? We eat rubbish food because you are going for easy, quick fix type of food, fast food, and you are causing a lot of damage to your own body. So I think that needs to change from us and tell people nutritional food is not high calorie food, and it is not expensive food. It is cheap as a chip. It is available around you. See the natural food, what is least minimally processed food with high fiber content. Feed your gut microbiome. Gut microbiome will serve you. It has got a huge role in the pain management. And get rid of sugar from our diet. That is the number one poison.
Thank you so much. I also want to add that in India, we, especially the northern part of India, we pay a lot of stress on taking haldi. That is, curcumin. It has curcumin
Yes.
and ginger. Like they both have analgesic properties. And maybe, in future, like holistic physicians like you will lead a pathway for us that we will start preemptively, the diet of the patient where we add ginger and curcumin for, better pain management in the perioperative period. So thanks again for showing us a new pathway and changing our perspective, like purely as an interventional physician. I don't see any questions in the chat box. If so, then should I hand over the mic to Jitendra then? Should we continue with the next speaker?
Thank you, ma'am. Yes, definitely. I have one question for Dr. Tatangal. Atmaja, what I wanted to ask was that you talked about cryoablation. So that would be effective in patients who have stump neuroma?
Yes. Yes.
So those who have a stump neuroma.
It is useful in stump neuroma if you have got, like, for example, knee surgeries, genicular nerves. The only thing about the radio frequency and the cryo, you should not do that to a motor nerve if you are worried about the mobilization. So then you go for pulse radio frequency. But if you're not worried about like a stump neuroma, you are not worried about the patient's mobility as such, cryo, radio frequency, alcohol, if that is, because that is the cheapest one available in India. So you can use the alcohol or phenol just for the neuroma. Yes.
Thank you very much. Thank you for such an lecture with such an insight. And I would again like to thank you to accept the invite and be with us. And Thank you.
you.
And we'll move on to the next talk. I would invite Dr. Nidhi Bhatia to introduce the next speaker. Nidhi is a dynamic young professor at PGI Chandigarh. She's a colleague and I've been working with her for quite some time. Her areas of interest are trauma and obstetric anesthesia. She has a special interest for airway management and regional blocks. She has authored several books and she has authored chapters in several books and has nearly 100 publications to her credit. Over to you, Nidhi.
Thanks a lot, ma'am, for that kind introduction. A very good evening to all. So we move ahead after those two very, very informative talks. Now, we are all aware that pain is the most common symptom which is reported in acute trauma patients. And equally common is its inadequate management or inadequate relief, which is frequently reported by patients, especially in the emergency. So it is important that we all know how to adequately manage acute pain. And at times, its management in emergency or in triage becomes quite a challenge. So to talk about it and tell us what is the latest evidence in the field of management of acute pain in trauma patients, we have with us Dr. Karan Singla. Dr. Karan is an assistant professor in the Department of Anesthesia at PGI Chandigarh. He is an avid worker and has a keen interest in the field of trauma anesthesia and critical care, and has been working in this field for the past few years with us. So I welcome you, Dr. Karan, and hand over the mic to you. So it'll be a great topic to listen to what are the challenges and how we can best deal with managing acute trauma patients, the pain that they have in emergency. Over to you, Dr. Karan.
Good evening. Good evening. Thank you for the opportunity to speak on this esteemed forum. So I'm Dr. Karan Singla. I'm an assistant professor in the Department of Anesthesia and Intensive Care. My particular interests are in trauma anesthesia and critical care. So the topic for me is management of acute pain in the triage. I was discussing something about the need for pain management, the assessment of pain, and the management of pain. Now, first of all, why pain management is required in the triage? So, pain is a major symptom of 90% of the patients admitted to the emergency department after a traumatic event. Data from the European countries, especially the Norwegian and the Italian emergency departments, show that only 14 and 32% of patients with moderate to severe pain actually received analgesia. 75%, almost 75% of the patients were discharged from the emergency departments with moderate to severe pain. Almost 2/3 of the trauma patients had to wait for up to an hour for pain relief at emergency departments. 2/3 of the patients report at least moderate pain 12 months after injury. So basically, this tells that there is an urgent need to address the pain that patients coming to the trauma center or after a traumatic event they undergo. So pain, it basically impairs respiratory functions, it delays immune response, wound healing is delayed. Pain increases the metabolic demands. Inadequately treated pain can result in delay in return to work, impair quality of life, can lead to post-traumatic stress disorders, or can lead to chronic pain syndromes. Now, first of all, to treat pain, we need to assess pain. So there are various tools for assessing the pain. In cognitively intact patients, I will just enumerate their numerical rating scales, the visual analog scale, there's a defense and veterans pain rating scale. For patients with cognitive impairment, we can use the behavioral pain scale, the critical care pain observation tool, functional pain scale. In older adults, we have the pain assessment in advanced dementia or the PANARD scale. For pediatric pain assessment, the most commonly used are the FLAX scores and the Wong-Baker Faces scale. Just running through the main pain ranking scales in the evaluation of subjects with trauma in different age groups. Less than 4 years, generally the FLAX score is used, which consists of the faces, the arms, the legs, the cry, the consolability. Up to again 4 years, the Wong-Baker Faces scales can be used. Over 4 years of age, the numerical rating score can be used. In adults, the visual analog scale again and the numerical rating scale are most commonly used. In the older patients, the pain assessment in advanced dementia, the PANARD scale is used. This is just a quick reference to the scale, the FLAX scale. We see the child's face, the legs, the activity, the cry, the consolability, the Wong-Baker Faces pain rating scales. They are the VAS scale and the numerical rating scale that can be used by adult patients who are cognitively intact. Now, regarding the analgesia for a trauma victim, there are basically four major modalities. First is the non-pharmacological treatment, the pharmacological treatment, the regional analgesia that is coming up in a big way, and the multimodal form of treatment. The non-pharmacological treatment, as has been discussed previously, which aim cognitive therapy, hypnosis, music therapy, virtual reality, or the physical therapy like TENS that has been discussed in the previous lectures. I'll not be dealing with the pharmacological treatment. The ideal drug for treatment in the triage is which is easy to administer, which is quick, has a very short half-life, is highly effective, and have minimal side effects. This is the WHO analgesic ladder that we generally use for pain treatment using a pharmacological method. Step 1 is non-opioids, step 2 is weak opioids, and step 3 is strong opioids. These are the lists that I've enumerated the drugs that are the pharmacological agents that can be used for treatment of acute pain in the triage. Acetaminophen 1000 milligram QID is the standard treatment. NSAIDs like ibuprofen, ketorolac, these are more commonly used. COX-2 selective NSAIDs, they reduce the risk of major upper GI bleeding and the hence preferred. Other commonly used drugs are ketamine, which is an NMDA antagonist in a dose of around 0.3 milligram per kg as a bolus or 0.1 milligram per kg per hour as an infusion. The opioids that are most commonly used in the emergency setting are the fentanyl in IV doses of 25 to 50 micrograms, then as an infusion of approximately 50 micrograms per hour. Morphine, especially in our setup, morphine is quite used and abused for giving analgesia to a trauma victim. The usual side effects of opioids like risk of addiction, life-threatening respiratory depression, tolerance, these are generally associated with these agents. Tramadol, again, it's a semi-opioid which is very commonly used in 50 milligrams QID doses, again for trauma victims. Acetaminophen and NSAIDs are the most frequently used drugs. However, a word of caution regarding NSAIDs, they can cause gastrointestinal bleeding. In patients with traumatic brain injury or with patients with intracranial hemorrhage, most practitioners avoid using COX-2 inhibitors. NSAIDs are known to cause increased risk of anastomotic failure. They are known to cause impaired wound healing and they complicate diagnosis of acute kidney injury. Opioids, they are a standard treatment. However, they have been limited by central nervous system respiratory depression, ileus, and tolerance. Long-acting products like transdermal patches, they are not used for trauma victims. Patient-controlled analgesia, These provide fast pain relief and are used for can be used for with higher patient satisfaction. Regional anesthesia is renal analgesia. In fact, is a modality for acute pain treatment that is coming up. Neuraxial techniques like epidural analgesia and paravertebral blocks are being used. Ultrasound guided facial plane blocks are being used. Extremity blocks are being used for providing analgesia in the emergency department. This is a summary of the regional techniques or the regional analgesia techniques that can be used. Epidural analgesia for chest and abdomen injuries or pain. Paravertebral blocks again for chest and abdomen injuries can be used in rib fractures, especially in rib fractures. Serratus interior block, these are the fascial plane blocks that are started being using for plane blocks, serratus interior block, especially for T9 to T2 to T9 anterolateral chest injuries, chest wall trauma, rib fractures, flail chest, and chest tube insertion. Transverse abdominal plane block, it is still not many studies have come up, but there is a potential to use this block for abdominal wall incisional pains, abdominal wall trauma. Quadratus lumborum blocks, again, these can be used. However, it being a deep block, it's generally considered it has higher risk for bleeding, especially in patients who are on venous thromboembolic prophylaxis. Erector spiny blocks, again, T2 to L3, chest, anterolateral, thoracic, and lumbar areas, or anterior and posterior chest wall trauma. Then the brachial, then the extremity blocks like brachial plexus block, interscalene, supraclavicular, they can be used for upper arm trauma. Femoral nerve blocks for hip, knee, and joint trauma. Fascia iliaca block has been studied very commonly, has been studied extensively for hip or femur fractures. Sciatic nerve block, again, not many studies, but yes, there is potential. However, important point is about peripheral nerve blocks is that there's always a risk for compartment syndrome. Like the compartment syndrome, the symptom might be masked by the peripheral nerve block. So peripheral nerve blocks have to be used with caution. Again, regional analgesia is a part of a multimodal analgesia. It provides superior pain relief compared to systemic analgesia alone, reduces opioid requirements, may decrease the length of stay. Continuous regional analgesia is preferred instead of a single injection technique when pain is expected to last more than 12 hours. For thoracic and abdominal pain, epidural and paravertebral blocks provide superior analgesia. However, again, as a word of caution, peripheral nerve blocks are, though not contraindicated, but they might potentially mask the compartment syndrome. One or two word about the neuraxial techniques like epidural and paravertebral blocks. They are indicated for multiple rib fractures, acute postoperative pain following laparotomy. They provide superior analgesia and improve oxygenation compared to IV patient-controlled analgesia. However, there's increased risk of hypotension, urinary tension, and lower extremity weakness. This was the trial which was published in the Journal of Trauma. This was comparison of continuous thoracic epidural and thoracic paravertebral infusion in patients with multiple rib fractures. They found that both epidural analgesia and paravertebral blocks, they provided good pain relief and improved the respiratory function, as evidenced by improvement in the visual analog scale, both at rest as well as on cuffing. Another clinical research paper published in the Journal of International Medical Research compared thoracic paravertebral blocks versus intravenous patient-controlled analgesia for pain treatment in patients with multiple rib fractures. They also found that paravertebral block and the IV patient control analgesia, they provided good pain relief. The VAS scores were significantly lower in the thoracic paravertebral blocks as compared to the IV PCA group during rest as well as during cuffing. Further, the patients in the thoracic paravertebral block, they showed higher respiratory parameters like FVC, FEV1 by FVC ratio, and the peak expiratory flow rates, and fewer complications than the IV PCA group. Regarding the ultrasound guided facial plane blocks, these are newer blocks that have been used in the acute setting with the advances in ultrasound guided regional analgesia techniques. They are easier than neuraxial techniques. They can be used in patients who have a requirement of thromboembolic venous thromboembolism prophylaxis. This was a article which was published in the Trauma Surgery and Acute Care journal, which compared the use of serratus anterior plane block with epidural and paravertebral blocks in trauma patients with multiple rib fractures. They found that all patients who received serratus anterior block or the epidural or paravertebral blocks, they demonstrated reduction in the pain scores. Though it was a retrospective study, but they did find out they did find a decrease in the pain scores with serratus anterior plane blocks. Another study was the use of with the effect of erector spinae plane block on respiratory analgesic outcomes in multiple rib fractures. This was again a retrospective study. There also it was found that the erector spinae blocks were associated with improved inspiratory capacity and analgesic outcomes following rib fractures without hemodynamic instability. Regarding the extremity blocks, compartment syndromes are, as we said, that it is an indication, it's a concern in acute trauma, especially when comminuted fracture crush injuries are present. So it might interfere in the timely diagnosis of compartment syndrome. However, a number of studies, this is the studies using the fascia iliaca compartment block for femoral fractures. These have been so commonly used that in the Western, especially in the European setup, the paramedics have been instructed or they have been trained to perform the fascia iliaca blocks for pain relief for femoral fractures. This article found that in the fascia iliaca compartment block, the median pain scores were less as compared to the standard care. The standard care was just the IV analgesics. There's another study in the Scandinavian Journal of Trauma, which said that pre-hospital administration of fascia iliaca block by emergency medical service nurses. So even they found that the median NRS scores decreased after block performance to a score of 6, 4, and 3 after half an hour. So another study from the Academy of Emergency Medicine, they showed a comparison of ultrasound guided 3-in-1 femoral nerve block versus parenteral opioids in emergency department with hip fractures. They again found that the femoral nerve block in adjunct to the standard therapy resulted in significantly reduced pain intensity and decreased amount of rescue analgesia. So again, ultrasound guided peripheral nerve blocks have been used, but they have to be used with caution. So as the multimodal analgesia is the need of the hour, use of multiple analgesics, regional anesthesia, analgesia, non-pharmacological interventions to treat the pain pathway. It helps in potentiation of medication effects and greater pain control. They may mitigate the risk profile of each medication or strategy, allowing for a synergistic pain control. So multimodal pain trauma approach in the pre-hospital settings, non-pharmacological strategies, short-acting analgesics like fentanyl or ketamine might be used in the emergency department on which we are focusing. Severe pain can be treated with the IV opioids, ketamine, ketorolac. Localized pain can be managed with the regional blocks. for breakthrough pain, oral opioids like tramadol can be used. In the perioperative setting, again, non-pharmacological settings, IV opioids, ketamine, NSAIDs, acetaminophen can all be used. A short sharing of our experience at PGI. We did a small study on early ultrasound guided brachial plexus analgesia versus systemic analgesia following complex hand injuries. The main objectives were to find out pain relief 1 hour following intervention, time to first rescue analgesia, total analgesic consumption, patient satisfaction, persistent post-surgical pain at 15 and 30 days. We categorized the patient into 2 groups. One group A had all the standard treatment, which included when the patient arrived to the trauma emergency, IV analgesics or opioids, as is the norm that was being done. Dressing and wound examination was done, radiology, and then sending the patient to the triage. Surgery and administered anesthesia, post-op analgesia was monitored. However, in the intervention group, upon arrival in the trauma emergency, infraclavicular brachial plexus nerve block with catheter insertion was used. These are the results that we found from our study. At arrival, the numerical rating scores were very high in both the groups. Percentage of pain, number of patients experiencing the numerical rating score more than approximately 7 to 10 were very high. 1 hour after the intervention, the NRS scores in the brachial plexus block group were very low. Pain scores during reassessment and during dressing again were very low in the brachial plexus block group. The rescue analgesia requirements again in the brachial plexus group up to 12 hours were again very low. We also followed up the patient for persistent post-surgical pain. At 30 days, in the brachial plexus group, the number of patients having persistent post-surgical pains were considerably less. So we found that the brachial plexus blocks resulted in superior analgesia as compared to standard regime. There were marked reduction in pain scores in the nerve block group. Incidence of breakthrough pain using necessitating use of IV tramadol was considerably less in the brachial plexus block. Duration of analgesia was prolonged. Pain scores remained low for approximately 16 hours following brachial plexus nerve blocks, and no supplements were required. And it also resulted in better satisfaction, patient satisfaction score as compared to systemic analgesia. So that's about it. So I would end in the saying that effective relief of pain is a universal human right according to World Health Organization.
Thanks a lot, Dr. Karan, for that very informative talk. Like you rightly said, managing acute pain and trauma patients, it requires a multimodal approach, definitely. And now regional blocks are the way forward, and there is a lot of recent evidence on arrival blocks in the emergency. But having said that, managing pain in the emergency or in the triage can often be very challenging as well. And like you mentioned in your initial slides, most of these patients, they are discharged from the emergency with moderate pain, but the management is delayed at times. So like what in your experience, or maybe going by the work you do in your setup or at PGI, like what do you feel are the barriers to effective management of pain in the emergency area or in the triage? What are the problems or the challenges or the barriers to its effective management?
So the most important barrier is basically sensitizing the residents or the doctors who are the first providers regarding management of pain. Sensitizing, assessing the pain, and recognizing that the patient has pain. Right, we work in the emergency department. Pain, analgesia the only thing that comes to our mind is either NSAID or an opioid. Uh, Sensitizing the residents about regional blocks, about peripheral nerve blocks, that is very important. And there's so much resistance for knowing about these blocks. Our emergencies are actually manned by surgeons and
Yeah.
orthopedicians
Yeah.
and neurosurgeons who aren't really concerned about
Yeah.
learning about regional blocks, which can be very effective.
Yeah.
So,
So yeah, I
so
feel the surgeons mostly they are focused on the surgical aspect, and
surgical
pain
aspects.
most of the times it's considered as a part of the deal. A little bit of pain
Right,
is okay in the emergency.
right,
So it's
right,
not
right,
taken.
right.
Yeah. And another reason could be maybe we lack protocols or a multidisciplinary approach, and most of the time patients also don't report it because they
Right,
think
right.
it's okay to have a little pain. So
Little
it's
pain, right,
underreported and not assessed properly. That could be another reason. Yeah.
right, right.
Thank you so much, Dr. Karan. I don't
Thank
see
you.
any other questions in the chat box.
Right,
Uh,
right. Thank you.
Dr. Nidhi,
yes, ma'am.
this is Dr. Sukanya Mitra. So can I make a comment on
Yes,
this?
ma'am.
Yes. Dr. Karan, excellent lecture. I just want to say that as my previous speaker, Dr. Atmaja said, we should be patient-centric. We should change the attitudinal aspect towards the lackadaisical attitude towards pain by our surgical colleagues, rightly said. But as being in Apex Institute, we may develop a protocol where we can use, things like fascia iliaca block in the emergency setup routinely. It could be included in the protocol, and it does really help the patients. This is a very simple block. And if incorporated in the protocol that we do this before shifting the patient, I think this will be of a great help to our innumerable patient who comes to the OT and emergency setup with the lower limb fractures.
Yeah.
I think
Yes, ma'am,
that's all.
rightly said. Yeah. Actually, we have started, especially in the upper limbs now, like Karan mentioned, the study that we did. As a part of that, it was a study where we gave on-arrival blocks. So it actually really helped. And once it starts helping, it's the surgeons who give you a call that please come and give a
Yeah.
block. Yeah.
Yes,
So
sure.
Right.
But I personally think that, brachial plexus block will need some amount of expertise. The junior resident also needs how to learn to use the ultrasound and do accordingly, take necessary precautions and etc. etc. But the fascia iliaca block for lower
yeah,
limb
that's
is
a
a
very
very,
simple
Right.
very
block.
easy block,
Yes, ma'am.
and it can be practiced even by, maybe a very junior resident can also be taught. And if you and me, like, from bigger institutes, we make it a protocol, I'm sure the patients will be immensely benefited.
Yes, definitely, ma'am.
Yeah, thank you.
Thank you,
Definitely.
ma'am.
Thank you.
Uh, I have one thing to ask from you. Did you come across any literature which says that on-arrival blocks, do they decrease the incidence of persistent post-trauma pain in these patients? Like,
Ma'am, right now, no. There is a study from Gangaram Hospital on arrival about on arrival blocks, but they
Ganga Hospital.
don't. Yes, Gangaram. So, oh, sorry, Ganga
Ganga
Hospital,
Hospital, Coimbatore. Yeah.
Coimbatore, sorry.
Yeah.
So they did a study on on-arrival blocks, but they did not see chronic pain, the conversion to chronic pain, they did not see. It was just on-arrival blocks.
Okay. Thank you, Karan. Nidhi, you want
Thank
to
you.
add something? Or
Yeah, there have been a few studies, not exactly, there have been studies on on-arrival blocks which have decreased the incidence of chronic pain, and they have improved the outcome and decreased the length of hospital stay. So there are a few studies indicating that. And to add on to what Sukanya ma'am had said, that fascia iliaca block is definitely a very easy block. And there is current literature in which fascia iliaca blocks have been given in the pre-hospital setting as well. even by the nursing staff.
And the
So it's that
paramedics,
simple, yeah, and the
yes,
paramedics. Yeah.
yes.
Thank you so much.
Thank you.
Thank you, Nidhi. Thank you, Karan. And we now move to the last talk of the day, and for that I would like to invite Dr. Ruchi Gupta. Dr. Ruchi Gupta is the professor and head at SGRT Medical College, Amritsar. Madam has a very keen interest in musculoskeletal pain, and I think trauma patient victims are one group of victims who have a very high incidence of musculoskeletal pain, and maybe her expertise, as Dr. Vanita talks, would add further to this lecture. Over to you, ma'am.
Thank you, Dr. Jatinder, for inviting me for this session. And I would take an opportunity to introduce my very good friend, Dr. Vanita. She is a professor at GMC 32 Sector Chandigarh. She is an achiever. So she has a lot of memberships and being faculty to various conferences and being organizing secretary for ICACon 2022, which was a grand success, and for various other CMEs on pain management. And she's not only like into pain, but she's a overall very good researcher and editor for and has best achieving a reviewer award and a lot of publications to her credit. So I hand over the mic to Dr. Vanita. But before I hand over the mic to Dr. Vanita, I would like to say that the topic which she's going to cover is extremely difficult and important, especially in post-trauma cases, because this phantom limb pain is a nightmare at times. And it's very, very difficult to cure. And in all amputations, around 60 to 70, rather, literature says 85% patients suffer from this phantom limb pain. So over to you, Dr. Vanita.
Yeah. Thank you, ma'am, for the kind introduction. And I would like to thank Dr. Jayashree, ma'am, Dr. Jitender, and all the members of ICA for inviting me for this, for the webinar. And a very good evening to all the esteemed faculty. My topic is the perioperative strategies for post-amputation phantom limb pain in adults. I'll just start my talk with this, picture. Do we know this personality? I'm sure even I did not know about him before I could, see that he has so many achievements to his credit. So how do we see the burden? The burden of, traumatic amputations. Now, this study was done in PGI Chandigarh, which came across, 17,000 trauma cases. And out of that, the 2.5% were major limb amputations. We can see they were in the relatively very younger age groups, the most productive age group for a country. Most of them were because of the road traffic accidents. And the on-site amputations were seen in 23%, whereas the limb amputations were, in 43%. So we can see that this also not only contributed to the morbidity, but also to the morbidity as well, mortality as well. And they had extended hospital stays because they had some other associated injuries also. Now, injuries is one aspect of trauma, but then the one more important aspect is pain, which we are going to talk in today's webinar. So we can see that amputations are one of the oldest and the most severe pains in the, in the human experience. Now you can see very well the level of the phantom limb pain if we see here in this scale, the Megul pain questionnaire, and phantom limb pain impacts up to 29, which is the lower, to 85%. So it's a wider range that we can see. And out of these, up to 70%, 10% of the amputees, they report a severe phantom limb pain. So the most common amputation cause in this part of the world is trauma. There's a few, terminologies which I'll be talking while giving this talk. One terminology is the residual limb pain. Now, residual limb pain does not equate to phantom limb pain. Residual limb pain can be because of the, a hematoma, a osteitis, a wound which is not healing, maybe seroma or improper fit of the prosthesis. Phantom limb pain is an entity in which the pain would persist, after the complete tissue healing, and maybe has got the typical characteristics, like it'll be complaining of cramping pain, burning, episodic, crushing type of pain. So if we see the ICD code also, describes the phantom limb syndrome with pain and without pain. So we need to make sure what are the distressing symptoms, and part of which pain is to be addressed. Now, what are the predisposing factors? They can be, pain having before surgery, seen more so in females, anxiety, depression. So these are the factors which would be predisposing. Plus, there is certain genetic mapping which demonstrates the hereditary presence of a certain genes, which predispose these patients for these pain syndromes. Now, the amputation pain has a unique challenge because, first of all, the pathophysiology, although is claimed to be understood, but still it remains understood. Like it's not understood completely. Pain may occur in a patient having a post-amputation in different stages a patient may present. It may be an acute perioperative pain, it could be a post-surgical pain, it could be a residual limb pain, it could be a phantom limb pain. Now, how do we understand the phantom limb pain? We can see that the distribution of the areas on the brain, as explained by Penfield Homilicus, that these areas have different distribution on the cortical areas of the brain. So these spread will these changes after the amputation. Now, if we see a normal, brain having a primary cortical distribution and a primary sensory distribution, so we can see the feet, the trunk, and hand. But after the amputation, there will be a cortical reorganization as seen here. Now, the phantom limb pain, as a perioperative physicians, as working in trauma centers, we can have certain preventive strategies, medical management, and also trying to reverse this cortical reorganizations. So acute stump pain was my previous speaker has spoken a lot about how to manage pain, the multimodal pain management. But then what about the residual pain? So that pain can be as a result of the myofascial pain, as I talked about the several causes. Now, balancing this may be sometimes difficult. Now, stump neuroma occurs as a result, a nerve which has been severed. And because of that, there's an altered sodium channel, and there is the thresholds are reduced. So when they try to grow, since it's an amputated limb, it may not be possible. So what happens is the patient starts developing a pain which is from the periphery as a result of the stump neuroma. Then there can be, heterostopic ossification which may be occurring. And this is because of the activations of these mesenchymal cells in the soft tissues. And as a result of that, they have certain, deposits of calcium in these soft tissues. And as a result, they start having pain. So if we talk about the peripheral mechanisms, which, because of the stump and the neuroma formation, deafferentation pain, going on to the spinal cord, it can be, the sprouting of these neuromas, increase in NMDA, brain having these cortical reorganizations, and having a change in the neuromatrix and in the neurosignature. So this we did a review article we had published. Now, peripheral mechanism, I just spoke about the ectopic discharges and the mechanical changes. At the level of the spinal cord, we can see that in the lamina 1 and 2, we have the A beta, we have the C fibers and the A beta fibers in lamina 3 and 4. Now, here also the anatomical reorganization starts occurring because of this sprouting into the superficial lamina. And as a result, the excitatory amino acids like glutamic acid and aspartic acid may start getting involved in this sensitization, wind-up phenomena starts occurring at the level of the spinal cord. Very interestingly, at the brain, as I told about the redistribution of that spread, so there might be a change in the neuro signature. So the pattern of activity which is generated by the brain based on one's awareness and perception, that also changes. So we can see the changes occurring at the peripheral level, at the spinal cord level, and at the brain level. So how to, first of all, most important thing is knowing the problem. So diagnosing, then having a pain assessment, depending on the different scales which are available to us. Then how to care about. Now, it's a huge matrix of people who will be managing this, starting from the surgeons, anesthesiologists, the pain physicians, the psychiatrists, and the rehabilitation team. Surgeons, they have certain surgical preventive strategies which also have a major role in prevention of the phantom limb, in which their surgeons techniques like ligation of large nerve fibers, preemptive coaptation. So these are the part of the surgical precautions that they take while doing those surgeries. Plus, there's a new concept of called the bionic reconstruction, where there's a restoration, the surgical and rehabilitation technique is being used, in which, the nerves are, being, at the time of surgery, they are doing a restoration of the physiological continuity, and they are trying to improve so that the prosthetic function is, is accepted, and there is better functioning of the newer, these prosthetics which are there in the market. This is especially for the upper limbs. Plus, for the anesthesia technique, we can have a different type of mechanisms, techniques we can use, starting from the, the PCAs, the ketamine infusions, then the gabapentinoids can be started even as preemptively for prevention of phantom limb pain, then preoperative institution of epidural infusion or a peripheral nerve, blocks, and then continuing them into the postoperative period. And then few have also mentioned the role of calcitonin. Plus, use of multimodal analgesia and the epidurals. There is no difference. I mean, you can use with the adjuvants, and then you can combine them with multimodal analgesic regimens. You can combine them with, the like adjuvants like opioids or ketamines or calcitonin. There are a lot of studies in literature, few of them favoring the institution of epidural and peripheral nerve blocks prior, a few not showing a very change in the, there is a change, there is reduced pain in the perioperative period. There is a reduced pain in a few months, up to 3 to 6 months. But some studies have mentioned that it may not be, present pain relief at 1 year. That is what a few studies have mentioned. However, these are the modalities which are available, for institution. If not, epidural is not possible, then peripheral nerve catheters and peripheral nerves, they can be used, as mentioned by my previous speakers also. However, whichever technique you use an epidural or a peripheral nerve, there is a favor tilt towards the use of them in the perioperative period. So you can use preoperative gabapentinoids. You can use the ketamine in a preoperative, or in the intraoperative, you can use an infusion. Intraoperative lidocaine infusions are also mentioned in the literature. Then tramadol has been found to have a significant relief of this phantom and the residual limb pains. So from a clinical perspective, besides these methodologies, which, we have seen, the techniques that we can use, we have a different array of drugs. Although the neuropathic pain claims that, the TC and the SNRIs are the first liners, but this may not be the same in phantom limb pain, where encouraging results have been seen with gabapentinoids, tramadol, and, use of ketamine, and as talked about earlier about neuromodulation, and also opioids. But opioids have a red star because they may be having more harm, than benefit when used at higher doses. So the one more modalities which can be, explored is the use of botulinum toxin in the peripheral stoma, the stump areas, where it has found to have encouraging results. And capsaicin has also been tried for the stump pain. Plus, there have been sympathetic blocks have been tried, like for the upper limb, we have the, the stellate ganglion block, which can be, used for the upper limb phantom limb pains. It can be given. And for the lower limbs, we have the sympathetic, the lumbar sympathetic block can be given. And we had this patient in our own institute where we gave it, and the patient had very good, benefit with this. Plus, the other techniques which can be used as a part of this is the spinal cord stimulator has shown encouraging results in several case reports. And but there was a survey done in UK where they said that the deep brain stimulation was considered more effective than the motor cortex stimulation. However, the literature still requires many studies for the randomized controlled trial studies to validate it. So now it is only, there are case reports which have been mentioned. The deep brain stimulation has been shown to be more effective as it is, likely to, affect the thalamic stimulation and the periaqueductal gray stimulation. And the motor cortex stimulation also has been tried, but then again, you can see here that they have been only case series. And so it is little difficult at this moment to predict like which, the treatment modality will be more beneficial for which patient. However, there have been case reports and studies done on the peripheral nerve stimulation, where a percutaneously implanted lead system have been, in the peripheral nerves, like in the femoral and sciatic, and patients have reported 50% more than 50% pain relief, which is a good pain relief in chronic pain. The cryoneurolysis also is a very encouraging modality where, the freezing inhibits the nerve conduction, and it produces natural effects like a numbing of a nerve, and it has shown very beneficial results. But yes, larger sample size studies are required. Now, the phantom limb pain is not just the nerves. We have to understand that because of this neurosignature and the neuromatrix changes, it has a lot to do with the cortical reorganizations, and the modalities available are the most easy and the cheap and the simple is the mirror therapy. Then we have these transcutaneous electrical stimulations. We have the deep brain stimulation techniques. And whenever we are doing it, because this aspect should not be ignored by by managing these patients, because this is a very important aspect, the brain cortical reorganization. And the prosthesis also needs to be taken care, because without the prosthesis, the functional part may not be taken care of in these patients. So I just want to mention that mirror therapy is valid, simple, and inexpensive. And it is very important that it should be given to these patients. So I would like to just conclude my talk by saying that the perioperative amputation pain relief is the most important thing, because it should start from there. Then we have these, patients who are having these the array of medications like anti-inflammatory, anticonvulsants, and they should be tried early. Then we have the non-pharmacological treatment, the physical therapies, pain psychology, and adjuvant therapy. And yes, definitely there is more scope and more, specialized services available. Institute should be referred. And thank you very much.
Thank you, Dr. Vanita, for such an extensive topic covered in such a short time. And I don't see any questions in the chat box. So I just want to share my own experience with this phantom limb pains. I've seen personally, when you treat them early, when they come to you in an early phase, so most of the modalities help. Whether you give synthetic blocks, you give medications, they do get some good pain relief. But as if you get phantom limb pains later on, say 2 year, 3 year down the lane, or sometimes they come even quite later than that, 5 years down the lane, it's very difficult to treat. So do whatever, you give any kind of block, any kind of things, it doesn't help. So what is your thing about, of course, as you said, perioperatively managing would be definitely a better choice. But treating them early would give them very good results versus late.
Yes, ma'am, I completely agree with you on this point, and that is why I highlighted the part of the, the cortical reorganization. Because
Yes.
at this point, it is only the, of course, all therapy has already been tried, and,
Right.
we have almost reached to the end of the ladder of the management of, for the pain in these patients. So here comes the role of these neuromodulation and using this cortical reorganization techniques, like whatever is available to us, whether like currently peripheral nerve stimulators are being, there, and we have spinal cord stimulators. So these are the modalities we need to be offered. But along with that, the mirror therapy, or the non-invasive brain stimulation techniques, those should also be offered to these patients, because every patient may not be able to afford the spinal cord or the peripheral nerve stimulators, but yes, they will be able to afford mirror therapy, TENS, or maybe the non-invasive cortical magnetic stimulations that may be available in certain higher centers where they can receive that.
Yeah, I agree with you. And I think CBT and all those, they also are very helpful. mindfulness and yoga and all those, they tend to reduce the stress on the patients. And I mean, I don't know how much but these patients are real difficult nuts to crack.
Yeah, actually, ma'am, I agree with you. It is probably the psychosocial factor which comes into play. Once the patient has amputation, the earning member of the house is gone, because most of the times the trauma victims are male victims only. So the earning member of the house is gone. They have so much of psychosocial stress also. So all that adds on to the development of chronic pain in these patients.
Jeet, can I make a comment?
Yes, ma'am. Yes, ma'am.
Yes. As Dr. Ruchi rightly said, that they're very difficult to treat, but I think Dr. Vanita had probably shown in one of her slides about repetitive transcranial magnetic stimulation, and that machine I think you guys have in PGI. So if it a very refractory, we might think of doing RTMS for those patients. A recent article in 2023, they have underscored the use of RTMS in this refractory phantom limb pain. So that could be useful. Another thing that while Dr. Atmaja was telling, even for the neuroma pain, like maybe a non-invasive, the pen therapy, that could also be taken into consideration, because that is a very simple technique and it is a non-invasive one. Why don't we try and see like if it has any effect? I think it will be beneficial to our poor patients.
Yes,
Yeah.
so Sukanya, I agree. I have used StimPod for almost 2-3 years, and I found that temporarily it was very effective. I use it on myself also for lot many times, but it has a temporary effect, but the cumulative effect or the long term effect is not there. So for this thing, I use in different modalities. This StimPod, it did help temporarily.
Dr. Ruchi, even I have used StimPod. We have used for chronic pain patients, as you rightly say. Yes, but it has to be used repetitively. Like,
Yes.
they need a number of sittings for that. And maybe the relief is for 3 months. But when everything is refractory, why not try something new? And if it helps the patient, after all, we should be more patient focused nowadays, and if we can help them, why not? And definitely RTMS remains one of the newer modalities in our armamentarium to deal with refractory neuropathic pain, like phantom limb pain.
Actually, I
Thank you very
looked
much.
up the literature. There is no definitive thing, because maybe multifactorial. So there is no definitive treatment which has been said for this phantom limb pain, because there are no RCTs, proper RCTs, or everywhere it is the literature is silent about it is talking about it, but not conclusive about it. So
Yes.
that's what I've seen.
Yeah, but no harm in trying some newer modalities when we have kind of given up. That's what I wanted to say. Thank you very much.
Definitely. If there is no questions, I hand over mic back to Dr. Jatinder.
Thank you, ma'am. Thank you, Dr. Vanita. Thank you, Dr. Ruchi. And I think with this, we come to the end of a very interactive webinar on post-trauma pain. We have tried to cover many aspects. And I will hand over the mic to Dr. Jayashri Sood. Ma'am is with us. She's in her car, planning to reach home now.
I think we can all switch on the cameras so that we can have the pic together. Dr. Kajal?
Kajal ma'am has requested
So I now invite Dr. Jayashri Sood ma'am to kindly conclude the webinar and give the vote of thanks.
I think she was in a car driving.
You are mute, Dr. Uma.
Yeah, actually, I was just trying to ring up madam. So, if you can just give me a moment, I'll just call her.
Yes, yes, that's okay. We'll wait for her. By that time, I would just give you an update. We have around 45 attendees on the other side, but probably, so we have one question here, which says, in a hemodynamically unstable trauma patient presenting to ED with trauma site pain, is it advisable to give regional blocks with local anesthetics in an unstable patient? Dr. Nidhi, we give this question to you. Nidhi, are you there?
Yes, ma'am.
So we have a question in the chat box which says, in a hemodynamically unstable trauma patient presenting in ED, is it advisable to give regional block with local anesthetics? I mean, but the question is that the patient might be already hemodynamically unstable. So are there any particular precautions which we need to take in this patient?
Yeah, at times you need to be very careful with the dose you give, though the analgesic doses which we give, they don't actually have a lot of impact on the hemodynamics of the patient, because these are mainly your analgesic doses which you are giving of local anesthetics. But definitely our concern would be on the amount of dose, and at times the volumes which we give, we have to cut down on that, and the concentrations. So just be careful about that. But most of the time, the analgesic doses that we give, at times they are not, they do not actually have an impact on the hemodynamics of the patient. So you can give if the patient is in a lot of pain, but have to be careful, be guarded.
And do you think adding an additive like dexmedetomidine,
Yeah, that is always
or
a rule.
dexmedetomidine will make a difference?
Yeah.
So yeah,
it does. Adding, we always, as a rule, do add an additive to that, so that it decreases on the dose, and plus it prolongs your duration of action, analgesic action. So that does help. So there is no.
Jeet, can I make a point?
Yes, ma'am. Yes, ma'am.
Yes, I think dexmedetomidine, one of the side effects is that it causes bradycardia. Now, for a hemodynamically unstable patients, like where the BP is low, the the heart rate obviously tries to compensate for the a lower cardiac output. So, like if you add dexmedetomidine, it can also have a deleterious effect. Won't fentanyl be a better choice in this case?
Definitely, ma'am. It is just that dexmedetomidine has a longer onset and probably fentanyl has a shorter action. So we need to, we need to strike a balance between various additives we have. Nidhi, you want to add something?
Or even dexamethasone is also very commonly used.
Yes.
Yeah, so that that does not have an impact on the hemodynamics, maybe.
We have Dr. Jayashri Sood with us. Now, we'll not keep the ma'am waiting for a long time. Over to you, ma'am.
I was enjoying. I'm sorry that in the middle I was attending the meeting as well. But thank you so much, Jitinder. That was, can you see me? Can you hear me?
Yes.
Yes,
Hello?
yes, ma'am. We can. Yes, ma'am.
Yes, ma'am.
Yeah, so
Yes,
that
ma'am.
was such an interesting topic and such an important one, and so well covered by all of you. And it was so nice to see all of you after a long time, and always a pleasure. Jitinder, so well moderated, and I can see Ruchi over there after a long time. I can't just help taking your names, and all of you, Kajal and Vinita, everyone was so good, and so also our faculty from abroad. And thank you so much. And we hope to meet again. And this was an excellent webinar covering such an important topic of this. So much, and good night. And thank you, Uma. Thank you, Shreya.
Thank you, ma'am. Thank you, ma'am. Thank you.
Thank you. Thank you, everyone. Thank you,
Thank
ma'am.
you so much. Thank you so much, everyone, for
Okay,
giving us the
good night.
opportunity.
Thank you.
Thank
Bye-bye.
you.
Good
Thank
night.
you. Good night,
Thank
Thank you,
everyone.
ma'am. Thank you, ma'am. Good night.
Bye.
Thank you, ma'am.
Bye.
Good night.
Good
Good
night.
night.